Advanced endoscopic rescue after failed endoscopic ultrasound-guided choledochoduodenostomy. These are disclosures of the authors. Endoscopic ultrasound-guided biliary drainage has become an established alternative in cases of failed or predicted difficult ERCP. In malignant situation, US-guided choledochoduodenostomy using electrocautery enhanced lumen-apposing metal stents allows for direct internal biliary drainage and are preferred over other US-guided drainage techniques. Stent misdeployment or migration remains a rare but severe adverse event, potentially leading to bile leakage, peritonitis, or duodenal perforation. A 46-year-old woman with an inoperable pancreatic head carcinoma presented with progressive jaundice and pruritus due to malignant biliary obstruction. Cross-sectional imaging revealed tumor infiltration and compression of the distal bile duct, as well as deformation of the papillary region. Because of this anatomical distortion, ERCP access to the papilla was very difficult, with prediction of a very difficult ERCP. After multidisciplinary team discussion, an US-guided choledochoduodenostomy was performed using a 6 mm diameter and 8 mm length electrocautery enhanced lumen-apposing metal stent. As shown in the US, from the bulb region, the bile duct was enlarged to 15 mm with a clear straight access to the bile duct from the duodenal bulb. US choledochoduodenostomy using electrocautery lumen-apposing metal stent with a 6 mm diameter and an 8 mm stent between the flange lengths was used. As seen on this slide, the access to the bile duct was safe under US control, and then in this first step of the release of the lumen-apposing metal stent, the distal flange is released under US control. Unfortunately, this release was slower than usual. US confirmed that the stent was opened between the duodenal wall and the wall of the bile duct, as shown here in these two US pictures. This schematic representation summarizes the situation we faced. We had a lumen-apposing metal stent in the duodenum, and between the duodenum and the CBD with an opening in the CBD. The rescue strategy in this situation is to insert a fully covered metal stent in the bile duct through the hole in the duodenum. As shown in this fluoroscopic picture, we were able to cannulate the lumen-apposing metal stent with a ERCP catheter and a guide wire, and contrast confirmed that we were in the bile duct. We next inserted a fully covered metal stent successfully under endoscopic and fluoroscopic control after we removed the lumen-apposing metal stent through the working channel of the echo endoscope with the forceps. Directly after initial successful positioning of the metal stent in the bile duct and in the duodenum, the stent started to dislocate. Maybe because of a too short length, maybe because of some resistance in the bile duct, but we were seeing under fluoroscopic control first the dislocation of the stent from the bile duct, and then under endoscopic control the dislocation of the stent from the duodenum in the paraduodenal space. This was confirmed by fluoroscopy and, as you can see, by endoscopy. In summary, we had a situation that the stent was dislocated in the paraduodenal space, so we had a hole in the duodenum and a hole in the bile duct. We first addressed the hole in the bile duct and did a forced dilatation of the papillary region and the duodenum to access the papillary region by a standard duodenoscope performing a standard ERCP procedure. After difficult cannulation of the bile duct, we were able to confirm the wire in the bile duct system. We performed a sphincterotomy over the wire and next inserted a fully covered metal stent by this standard ERCP technique in the bile duct. As you can see, There was a clear tailor in the area of the tumor, and we still confirmed the dislocation of the initial fully covered metal stent in the paraduodenal space. This standard ERCP approach was initially not performed because the papilla region was not accessible without increased force, and the papilla region was completely compressed through the tumor. So in the end, the standard ERCP was quite difficult, and to avoid pancreatitis and or perforation through standard ERCP, the initial choledochoduodenostomy approach was chosen. So in summary, we had the situation that we had successfully covered the hole in the bile duct with a fully covered metal stent, but still had a hole in the duodenum and the dislocated metal stent in the paraduodenal space. To retrieve the dislocated stent in the paraduodenal space, we used the standard forceps through a duodenoscope, which was introduced to the hole in the duodenum under endoscopic control. Unfortunately, we were not able to get hold of the stent in the paraduodenal space by this strategy. To retrieve the dislocated stent, we introduced a 9mm cholangioscope through the duodenum and through the wall opening in the duodenum. Using a cholangioscopy biopsy forceps, we were able to rotate the dislocated, fully covered metal stent to get access to the removal thread. The removal thread then was grabbed with the cholangioscopy biopsy forceps, pulled in the working channel of the cholangioscope, and by this we were able to get hold of the dislocated stent and en bloc pull this stent out with the duodenoscope and the cholangioscope, and by this retrieve the dislocated, fully covered metal stent from the paraduodenal space. We finally addressed the hole in the duodenum. Since the bile duct was directly lying behind this hole, we decided against an over-the-scope clip, which danger of attaching the bile duct together with the duodenum in the over-the-scope clip. Using dedicated closure clips, the Mantis clips, we were able to successfully close the duodenal wall under endoscopic control. Fluoroscopy showed no leakage of air or contrast. So summarizing the final situation of the end of the procedure, we had the duodenal stent closing the hole in the bile duct and the closure clips closing the hole in the duodenum. The complete procedure lasted 90 minutes, was performed under CH2, and no relevant pneumotoneum was detected. The patient received a single dose of broad-spectrum antibiotics. The patient was monitored in the intensive care unit for 12 hours. And CT scan after the procedure confirmed that the clips were successfully closing the duodenal wall and no bile leakage, abscess, or relevant pneumotoneum was detected. Oral feeding was reintroduced 24 hours after the procedure. The postoperative course was uneventful and the patient was discharged 4 days after the procedure in good condition. At the follow-up, 2 months later, the patient remained asymptomatic with normal bilirubin levels. Cross-sectional imaging confirmed stable positioning and function of the biliary stent without signs of leakage, infection, or abscess formation. The underlying pancreatic malignancy was stable and was managed palliatively. In conclusion, endoscopic rescue after LAMS misdeployment and stent migration is feasible in expert hands. Maintaining guidewire access and utilizing advanced endoscopic procedures outside the gastrointestinal lumen and employing advanced closure techniques are essential components. With these techniques, successful minimal invasive management strategy in such complex scenarios is feasible.